Hi, everybody out there in virtual NTI land. Welcome to NTI, and thank you so much for coming to my presentation today. You had me at sugar, understanding the physiology and management of diabetic ketoacidosis. My name is Eugene Mondor, and I'm clinical nurse specialist at the Royal Alexandra Hospital in Edmonton, Alberta, Canada, and it is an honor and a privilege to be here today and talk to you about DKA. For full disclosure, I have no conflicts of interest, no product endorsement. I don't think I'm going to mention anything that would be, talking about a particular product. But if I happen to do, nobody's paying me to say that. I'm just, talking about stuff that I've had experience with in our intensive care unit. If you want to get a hold of me during the conference or after the conference, critical care is such a small world, and I like staying in touch with everybody. So if you've got a question about DKA and you're not comfortable asking online at the live Q&A afterwards, feel free to give me a shout at heartlung44@shaw.ca, and I would love to hear from you. There is a class code for today's presentation. It's V75M366. So that's good for your evaluation. And although we're not in person, we are virtual, we're kind of in person. I like to keep my presentations live and interactive and like we're having a conversation with one another. So if you want to use the chat box and throw questions in the chat box, I'll be monitoring that during the presentation. Or if you want to ask something afterwards, that's great. And if you're by yourself at home, I want you to think out loud. I want you to look at the camera. I want you to talk to yourself, because I do that lots of times. If you're with a group of people, a group of friends watching NTI, talk amongst yourselves, have some dialogue and some discussion. That just makes us a richer critical care team. So going to have some fun with this today. I've got some questions that I may ask you to answer. I've got other things, questions I might pose to you. So it's all about stimulating and learning and having fun. So when we look at our objectives for today, we want to explain the pathophysiology of diabetic ketoacidosis, and it's really like putting a jigsaw puzzle together. But all the parts and pieces aren't fitting. So when we see these patients that are admitted to progressive care or step-down units or the adult intensive care unit, we have to figure out all the different moving parts and pieces and put that back together again. We're going to look at the signs and symptoms we might see in patients admitted with a diabetic ketoacidosis. We're going to describe the management of DKA and what do we need to do as critical care professionals to help get our patient better. And then we're going to summarize by looking at some of the complications and preventative actions that we can use when we see these patients admitted to our hospitals. So like I mentioned, I'm at the Royal Alexandra Hospital in Edmonton, Alberta. We're a level 2 teaching and trauma facility. We currently have approximately 870 beds. We are full service medicine, surgery, trauma, high-risk obstetrics, state-of-the-art cardiac catheterization center. We have an orthopedic standalone center that sees lots of total hips and total knees. We have an addictions and mental health center in our hospital, and one of the first, I think we were the first hospital in Canada and one of the very first in North America where we had a safe consumption site. So patients that are admitted to hospital with addictions, issues, drug use, misuse, and they have to have a consult with our addictions and mental health recovery team. And then we have an on-site center in our hospital where the patients are permitted to snort or inject while they continue to receive their care. Lots of good success with that. Lots of close eyeballs on that to see how it's going to work. And I have heard that it has transposed to other centers across North America, which is great. In our adult ICU, we have 30 beds. It's normally a 1-to-1 or 1-to-2 patient ratio. We have approximately 170 staff nurses, 50 support staff, 11 intensivists, and our emergency department is one of the busiest in Western Canada. In their busiest shift, they can see upwards of 1,000 to 1,500 patients, and during the pandemic, we were Western Canada's biggest and busiest hospital. So super proud of all of the good work that is done at the Royal Alexandra Hospital in Edmonton, Alberta. So if you ever find yourself 5 hours north of the great US-Canada border, directly above the great state of Montana, pop in, and I'd love to see you. Well, when we're talking about diabetic ketoacidosis, it is the most common hyperglycemic emergency that we will see in the intensive care unit. For a long time, we thought it would only occur in type 1 diabetics, but it occurs in type 2 diabetics as well. The pathophysiology is either an absolute loss of insulin, where the body is not making any insulin at all, or there's a relative deficiency of insulin. And before I go any further, I'm just going to tell you right now, I'm going to start repeating lots and lots of things, because with our jigsaw puzzle and our parts and pieces we need to start assembling, there's lots of interconnectivity, and it is like a puzzle, putting all the parts and pieces together. So if I repeat myself, it's not like an Oliver Stone movie where I'm trying to make a point and hammer you over the head with it, although I maybe sometimes. It's just because everything is so interconnected. The etiology of DKA varies around the world, and whether it's a physiological stressor like you're having the big jammer, or an acute pancreatic attack, or a GI bleed, or it's a change in medication that's changed the metabolism in your body. Those are all different reasons why DKA can occur. It's a potentially life-threatening medical emergency. Early diagnosis and effective urgent intervention is essential to save the patient's life. And left untreated, there is an increase in morbidity and mortality that we'll talk about in a little while. So our key learning point here for diabetic ketoacidosis, first key learning point: 1, there's a diagnosis of hyperglycemia or new onset diabetes, or an existing diabetic condition. 2, you've got a high anion gap metabolic acidosis. Don't worry if you don't know what it is. We're going to talk about it. And the accumulation of ketones, or ketone bodies, or acids in the human body. So there's 3 criteria that fulfill the definition of ketoacidosis. You've got your hyperglycemia, your high anion gap metabolic acidosis, and the accumulation of ketones. So when we look at hospitalized patients with DKA, about 9 to 14% of all hospital admissions are DKA. 2/3 of those are in type 1 diabetics, and 1/3 is in type 2 diabetics. We had seen a decrease in DKA up until about 2010. Newer developments in insulin, really good patient education strategies, having a really good success with decreasing the amount of DKA. But in the last 15 to 20 years, we have seen a steadily increasing number of adult patients admitted to hospital with varying degrees of severity of diabetic ketoacidosis. 1, the age of the population is increasing. 2, diabetes is becoming much more prevalent. 3, we would be remiss if we didn't talk about the influence of the socioeconomic, sociocultural factors, patients being able to afford going to a doctor, being able to afford medications. So those are all factors that are playing into that. When we look at hospitalized patients with DKA, there's a predisposition to being Caucasian and female. When we look at deaths are usually attributable more to the older patient with pre-existing concurrent illness. And even though I said the mortality rate was high, it's still pretty decent. It's at less than 1%. And when we look at mortality, it's often influenced by patient age, the primary cause of the DKA, because there's lots of different causes, and the level of dehydration or fluid volume deficit when the patient comes in. When we look at recurrent DKA, this is more than one DKA episode per year in a patient admitted to hospital. Lots of different implicating factors such as noncompliance, previous DKA episode. You're kind of bordering between type 1 and type 2 diabetes with that high hemoglobin A1C. And then our social considerations: lower socioeconomic status, mental health issues, eating disorders, strong correlation in the literature about folks that have some of those illnesses and those conditions and a coexisting diabetes, that they're not really probably taking as good a care of themselves as they could or should, and do end up in the hospital on more than one occasion. And without question, certainly a huge impact on our healthcare system. So before we start talking about DKA proper itself, let's look at what happens under normal blood glucose metabolism. So glucagon, in response to a low level of blood sugar, is released from the pancreas. And this is really the primary culprit in diabetic ketoacidosis. So glucagon, that hormone that's secreted from the alpha cells of the islets of Langerhans of the pancreas, stimulates glucose production in the liver. So what happens next? You get an increase in glycogenolysis, which is a breakdown of glycogen into glucose. You get gluconeogenesis, which is glucose being produced from non-carbohydrate substrates, and you get a breakdown of fat. And this really forms the basis and the stimulus for helping to elevate blood glucose sugars in the body under normal conditions. It's also partly responsible for what happens in DKA as well. Fats, triglycerides, will undergo ketogenesis to form ketone bodies, but in a healthy individual, the ketone bodies are very minimal. So the body is able to eliminate the ketones and you don't have the buildup in acid. As a result, blood glucose levels rise and we're very happy. Under hyperglycemic conditions, glucose will enter the pancreatic beta cells, insulin production occurs, so you get that release of insulin, which is going to decrease the conversion of glycogen to glucose. It's going to inhibit gluconeogenesis, so we're not going to be making glucose from all these extra precursors that are out there. In the presence of insulin, both adipose tissue and skeletal muscle tissue will increase their uptake of glucose, and as a result, blood glucose levels decrease. So it's a very fine balance between having too much and not having enough, and the body under normal circumstances does an excellent job of regulating blood glucose. But when we look at the pathophysiology of DKA and you have an alteration in blood glucose metabolism, we're either going to have an absolute or relative deficiency of insulin. So in diabetic ketoacidosis, one of these two things has to happen. In an absolute, the body is not making any insulin at all, but in a relative deficiency, it could be non-compliance. I just don't want to take my insulin. It could be omission. Maybe I forgot to take it. Lots of literature suggests in children and teens trying to fit in with their friends, wanting to go to a restaurant and have a burger and fries and a shake versus eating a salad. All that plays a role in it. It could be increasing insulin requirements with a relative deficiency because we're having the big jammer or a GI bleed or there's an infection somewhere in the body. Or it could be a new onset diabetes that just hasn't been diagnosed yet. So with the absolute or relative deficiency of insulin, counter-regulatory hormones are released. That's your cortisol, your glucagon, your growth hormone, your catecholamines. Those elements will all stimulate blood glucose production. At the same time, there's an inflammatory response that accompanies DKA, much like an inflammatory response in trauma or in sepsis and septic shock. The inflammatory mediators, the tumor necrosis factor, the cytokines, those are released, and that also stimulates the body to start producing more blood glucose. So you've got your counter-regulatory hormones, your inflammatory response, and that really forms the foundation for a DKA event. So the body will attempt to increase blood glucose levels. So again, the glycogenolysis, the gluconeogenesis, it will start impairing the uptake in the peripheral tissues. So they don't need as much glucose. So it'll start sort of having a shutting down, if you like. The patient will respond with a brisk osmotic diuresis in response to the increased blood glucose levels. And because the lack of insulin is not permitting the glucose to get into cells, the body's not dumb. It's pretty smart, and it's thinking, I need to find an alternative source of energy. And where's the first place it's going to go? It's going to go to the fat tissue, the adipose tissue. So immediately there's going to be an increase in the triglycerides. So the breakdown of no increase in triglycerides, a breakdown of triglycerides, an increase in free fatty acids, and glycerol. So when the triglycerides start breaking down, the free fatty acids will generate to form acetyl coenzyme A, which we'd be, it's like a Cher concert and no costume changes if we don't mention the Krebs cycle in a DKA presentation. So some of the acetylcholine CoA will enter the Krebs cycle and be used for energy and generate ATP. But because it's being generated faster than it can be eliminated effectively, some of the acetyl coenzyme A oversaturates and we get the Krebs cycle and we get into a ketogenic pathway. So when that happens, the body starts forming in the liver under an oxidative process, ketone bodies are produced. So the breakdown of the triglycerides occurs in the cytoplasm of cells. The free fatty acids are transported in the blood attached to albumin, and the ketone bodies are produced in the liver. There's 3 different acids that are produced: the acetone, the acetoacetate, and the beta-hydroxybutyrate. The acetone is what gives the odor, the fruity breath when the patient comes in with DKA. That's the breakdown of that acid, but it's the beta-hydroxybutyrate. That's the one we need to measure, and that is implicated most importantly in diabetic ketoacidosis. We also talk as well about minding the gap, and it's not the store, but it's the anion gap that we need to think about when we're looking at DKA. We know ketones can be used for energy. They accumulate much faster. So when we talk about a metabolic acidosis or a high anion gap, it's just we've got the bicarbonate that's trying to buffer the acids, and as a result, our bicarbonate levels start decreasing. And as the acid levels start increasing, that's where you get the gap. So it's a difference between your anions and your cations. And so that as that gap increases, that's a clue to us as critical care nurses that we've got a metabolic acidosis happening. So what else happens in response to the lack of insulin? And then we've got the triglycerides and the ketones that have broken down. What happens is that ketones and glycogen, they catabolize or break down to form more glucose. The liver starts forming reactive C protein. The macrophages produce some pro-inflammatory cytokines, which just feeds on that inflammatory response. Alanine levels start rising in skeletal muscles. So skeletal muscle starts breaking down because we, at the end of the day, want to produce more glucose. And then you get this massively fluid volume depletion situation that occurs. And as a result of the hyperglycemia and the diuresis and the profound fluid volume depletion, we have lots and lots of things that all start moving at the same time. You have the movement of fluid from the intracellular to the extracellular space. That's not only going to dilute your serum sodium, but it's going to contribute to an osmotic diuresis. So lots of high output is going to happen. The patient's going to become incredibly volume depleted. They're going to lose sodium, potassium, chloride, phosphate, magnesium. So all your electrolytes are going to start going out of balance. In peripheral circulation, because it's going to start shutting down, the cells will switch from aerobic to anaerobic metabolism. As a result, lactate levels will increase, which further contributes to the acidosis. The kidneys, because there's a decrease in blood flow to the kidneys, will decrease its glomerular filtration rate. Glucose will not be excreted as readily as it once was, and now we have further contributes to increased blood glucose levels. And then you get the free fatty acids that are going to impair nitric oxide, and you just get this whole feedback loop that just feeds upon itself, and the condition continues to get worse and worse and worse. And at the same time, the electrolytes are going, well, hey, what the heck is going on here? So you'll have a pseudo hyponatremia. So it looks like you've got and you truly do have a sodium deficit, but that's in relation to the osmotic diuresis that has occurred. It'll look like you have a mild to increased potassium, but you truly have a total body deficit of potassium. And so with the acidosis and the lack of insulin, blood samples don't truly reflect what's happening in the body. We've got all the electrolyte losses. And then to compound this, the renin-angiotensin-aldosterone system activated by dehydration kicks in, and now it's going to retain sodium and excrete potassium. And at the end of the day, you have what we call all aboard the hot mess express. You've got your hyperosmolarity because of the profound fluid loss from the body. You've got the development of ketones, which contributes to acidosis. You've got high blood sugar levels, significant electrolyte imbalances, and the body is thinking, what the heck is going on? This is the pathophysiological basis of diabetic ketoacidosis. So if I was to ask you what's currently reported as the most common reasons why DKA occurs in patients, would you say it's a new diagnosis? It's alcoholism, starvation, and malignancy or cancer? Is it infection and social factors? Or is it medication, the existence of diabetic diabetes already in a patient and a concurrent illness superimposed on top of that. So if you were to pick one of those answers, which do you think is most likely the most common reasons why DKA occurs in patients? And I think I might have helped you out already at the beginning of the presentation. I know what you're thinking. Could be new diagnosis. It could be. Could also be the introduction of a new medication. But if you were to say that it is the infection and social factors, you would be absolutely correct. That is the most common type. So when we look at causes of DKA, they talk about the 5 I's when you read nursing and medical literature. So infection, ischemia, insulin, intoxication, and iatrogenic. The most common reasons in type 2 diabetics that present with DKA is infection. And it could be a chest infection, such as pneumonia, urinary tract infection, or something happening in the gastrointestinal tract. When we look at the most common type of DKA, or the most responsible factor in type 1 diabetics, it's non-adherence. So you can see that there's a huge number of things that can cause and predispose patients to DKA. When we look at DKA proper, we need to, there's a few variations of it. You can have your alcoholic DKA, and you can have a starvation ketoacidosis as well. And just last week, we had a patient in the unit with an alcoholic DKA. And I thought, well, how fortuitous is this? I am just going to be talking about this at virtual NTI next week. And as I was sitting down and I was talking to the nurse, and everything was coming to fruition. History of chronic alcohol use, had been out and celebrating and probably drank much too much than what he should have. When we looked at the patient's labs, he had the ketones, he had the beta hydroxybutyrate, and the number one presenting symptom when he came to hospital was the protracted sort of vomiting. So the key distinguishing feature between DKA proper and an alcoholic diabetic ketoacidosis is you're not going to see that huge increase in blood glucose levels. You won't see it because his pancreas is continuing to function normally. And that's the key distinguishing feature here. And there will be the acidosis, so you will have the ketones, but you won't see that increase in blood glucose level because his pancreas continues to function normally. You will treat this patient as though he is DKA, and how you make the diagnosis is 1, clinical history, 2, the presence of ketoacidosis, and that correlated with the presence of alcoholism or an acute alcohol withdrawal is confirmatory for alcoholic ketoacidosis. When we look at starvation ketoacidosis, we can see this sometimes in folks with psychiatric illnesses and eating disorders. We can see it in different types of malignancies. They're just not taking enough kilocals in. So it's usually about less than 500 kilocals, but it's over a prolonged period of time. We'll still see the lipolysis or the breakdown of the triglycerides. You'll still see the ketogenesis or the formation of ketones, but you won't see really significant increases in the ketones or in the degree of acid-base imbalance. And that's because the condition has developed over several days is that the kidneys have been able to compensate. So not only has the individual adapted to the prolonged fasting state, but the kidneys have been able to compensate for the acidosis. So the acid-base balance and the electrolyte abnormalities are often very small or minimal, if not at all. So management of the patient with the starvation ketoacidosis really is primarily the infusion of dextrose and correction of electrolytes. So here's our first situation. Well, here's Adam. Adam is 56 years old. He has feeling unwell for 4 or 5 days. When I read the nursing histories these days, it all seems to be like that, doesn't it? It's like feeling unwell at home for 4 or 5 days with a history of nausea, vomiting, and fatigue. That seems to be what I'm seeing predominantly in patients coming to the ICU until we can get it sorted out. So his partner describes lots and lots of vomiting. He's got a history of hypertension, gastroesophageal reflux disease, and type 2 diabetic. So we can see on clinical assessment that the patient has a Glasgow Coma Scale score of 13. He's afebrile. He is tachycardic. His blood pressure is in the 90s, and we know our definition between stable and unstable is stable is over 90, unstable is less than 90 in critical care world. So he's in the 90s, so we're still dry, but he does look extremely dehydrated. He's breathing at about 30 to 35 breaths per minute, quite deep, slightly labored. The nurses say it kind of looks like Kussmaul respirations. And he's got a little bit of a fruity odor to his breath. His chest is clear, anterior, posterior, O2 sats 92% on nasal prongs. When we've done the blood work, his pH is 7.3, his bicarb is 16, so he is acidotic. The anion gap is elevated. The beta-hydroxybutyrate, so the acid, the ketone that's produced in the liver, is also elevated, but his blood glucose is normal. It's 10.7. So my question to you as we're deciding the disposition of this patient, is this patient in ketoacidosis? He seems to fit the picture. He's got the low pH, he's got an anion gap, he's got ketones, but the blood glucose is normal. Have you seen this? So this patient is in ketoacidosis, and there's a lot of literature coming out. And at the same time, we had our alcoholic ketoacidosis in the unit. We had a second patient that was on the unit with a euglycemic DKA. So a euglycemic DKA is really, really fascinating. About 3 to 9% of patients with DKA will present euglycemically. They have a normal blood glucose. The primary culprit that's been reported most frequently in the literature, and there's just a plethora of articles coming out in the last couple of years, it's the SGLT2 inhibitors, so sodium glucose co-transporter inhibitors. And what these medications do is that they prevent reabsorption of filtered glucose in the proximal tubules of the kidney. So it's used primarily in type 2 diabetics to help improve blood glucose control in combination with both diet and exercise. Now, there's certainly other reasons why people could present with a euglycemic DKA, liver disease, paramedics perhaps giving slightly more insulin than what is required in the ambulance on the way to the hospital. Diagnosis is difficult because what throws people off is the euglycemia. They fit the bill with everything else, but because they have normal blood glucose values, we tend not to think of the euglycemic DKA. So over 50% of patients that present to the EDs, not blaming anybody, let's use this as a teaching moment, with euglycemic DKA are misdiagnosed. The signs and symptoms can be variable, but when we treat, we're going to treat as per DKA management guidelines. So with euglycemic DKA, you've got a high anion gap metabolic acidosis, positive serum ketones or urine ketones, but you have normal blood glucose levels. And it is the SGLT2 inhibitors that are the primary factors. And so there's lots of factors, lots of hypotheses on why this occurs. We know that patient and family education is important. I have a friend right now who's on an SGLT2 inhibitor, and she's always checking her urine and she's always checking her ketones. And I think the number one question that comes up is, if I start detecting ketones in my blood, what do I need to do? The literature, and you talk to the diabetic specialists, are pretty specific that 1, you need to stop the drug. 2, monitor your blood glucose. 3, administer insulin. 4, consume some type of carbohydrate with probably about 30 grams. You need to hydrate yourself with water and continue to monitor your ketones and your blood glucose frequently. If that does not resolve the problem, you need to have plan B, and you need to determine if I'm going to go see my primary care provider or if I'm going to go to the hospital in the emergency department. So always have a backup plan, but patient and family education, and especially when we see a lot of these patients being discharged now on the SGLT2 inhibitors, we have a real responsibility to make sure our patients know that diabetic ketoacidosis is unfortunately an adverse effect of taking this medication. Well, here is Harmony. Harmony is a 29-year-old female who's been unwell for 3 or 4 days. She's presented to the hospital with fatigue, nausea, and excruciating abdominal pain. Her mom said she didn't eat very much supper. She went to lay down in the bedroom. When mom went to wake her up a few hours later, she was very difficult to rouse, although she was semi-responding. So mom called EMS. The paramedics arrived. She was determined to have an altered level of consciousness and hypotensive. So they started some large bore IVs. They administered some oxygen. They were checking her blood glucose levels, and they were en route to the nearest facility. On the presentation to the emergency department, her Glasgow Coma Scale score is 10. She's febrile at 38.7 or a temperature of 101.6. She's in sinus tachycardia when we hook her up to the cardiac monitor. She's cool and pale, a little bluish. The blue tinge is sort of perked up with the administration of oxygen. There's no edema. By cuff, her blood pressure is 83 on 52. Which probably gives me a map of about 60 or 62, just doing a quick calculation in my noodle. Respiratory rate is 30. It's deep. It's slightly labored. Chest, she's got fine crackles anterior and posteriorly. We have her on O2 at 15 liters by oxy mask, and her SATs are only 89%. She looks incredibly dehydrated and dry. She is still clutching her abdomen with some abdominal discomfort. She's had a Foley catheter inserted with a small amount of urine. They did take her to diagnostic imaging, and the CT of her head is fine. So I'm thinking, what else would you like to know besides she has an IV currently going at 150 cc's per hour, and the order is to maintain a systolic greater than 90 and a MAP greater than 65. If you were working with the emergency department team or the team in the ICU where this patient is most likely perhaps going to be admitted, what other key pieces of information would you like to know? You want a blood gas? I heard you. Absolutely. So here's our blood gas. pH is 6.71. PaO2 is 91, so she's not hypoxemic. The CO2 is 35. Your bicarbonate is 9, with a SAT of 89% on 15 liters by oxymask. The orders are to maintain an SpO2 greater than 90 and aim to normal ABGs. What else would you like? CBC, good. Electrolytes, yes. You want to check the gap. Excellent. You want to do a lactate? Yeah. Serum osmo? Yes. All good things as we start working this patient up for potentially diabetic ketoacidosis. So her hemoglobin is 13. White blood cell count's 21,000. There's her electrolytes that you can see. Her blood glucose is 720 milligrams per deciliter. So for my Canadian friends, that's 40 millimoles per liter. She has a gap of 29, a serum osmo of 295, and there are ketones in her urine. I think we would all agree Harmony is not very harmonious right now. She's a little disharmonious, and I think we would potentially agree this is a ketoacidosis. So we're going to have to do a little bit deeper dive, but we need to get Harmony admitted to the intensive care unit, I think, or maybe she'd be better on a step down or pulmonary progressive unit. So we'll think about that for a moment. So when we look at the precipitating events, again, it could be new onset diabetes, it could be infection. Mom was saying that she was coughing up some yellow sputum over the last couple of days, so potentially there's something there. She's a young lady. We don't know if she's been taking her insulin regularly, if she's been eating regularly. Mom said she didn't have supper, but we don't know if she's been taking her insulin as required. We don't know where she's been storing her insulin, because there's some reports in the literature that not only is it the poor adherence, but it's storage issues, that insulin starts denaturing itself and not as effective. Considering there's probably some associated chest infection with Harmony. We don't know if she started on any new medications or not. I can tell you she's got a history of back pain, recreational marijuana use, and generalized anxiety in addition to her type 1 diabetes. So I'm not sure if some of those factors play into that. So those are things that we're going to have to investigate, but I think we've got bigger items to address initially. Clinical examination, what the patient will tell you, polyuria. I'm always having to go to the bathroom. Polydipsia. I can't drink enough water. They're weak. They've got fatigue. There's generally some weight loss. But what you will see clinically is that extreme state of dehydration. Poor skin turgor, extremely dry oral mucous membranes. the ketoacidosis, you'll be able to smell their breath from probably the door of the room, and then that diffuse abdominal discomfort. And that's the thing that we really need to tease out here. What's happening with the abdominal discomfort? And is it something we need to be worried about? So over 60% of patients that present with DKA present with acute abdominal pain, and that can really mimic the acute abdomen. So it could be an ileus, it could be a blockage, it could be a bowel perforation. So we need to start teasing that out. So when patients generally present with DKA, the white blood cell count is usually not elevated significantly, even though there's a diffuse inflammatory response. So when it's under 20,000, that's usually not worrisome. But if it happens to be approaching like 21, 24, 25,000, correlating that with our clinical assessment of the patient, we need to start thinking, is perhaps the trigger for DKA a perfed bowel? Is there something gastrointestinal going on? So we know that the degree of abdominal pain will correlate with acidosis. So the higher the degree of acidosis, the more abdominal pain you have. So we have to be cognizant and reasonably prudent and start ruling out other potential causes and just not jumping on the bandwagon saying, yeah, it's DKA. What you will find if it's abdominal pain related to the DKA is within the first 24 hours of treatment with the therapy that we're going to provide Harmony is that the abdominal pain will dissipate or decrease. When we're looking at sort of loss of consciousness as well, less than 20% of patients that present with DKA are truly stuporous or comatose. And we know there's a direct correlation between the degree of hyperosmolality of the blood and the decrease in levels of consciousness. So when you get blood glucose levels in excess of approximately 600 milligrams per deciliter, or for my Canadian friends, 33 millimoles per liter, that's when you'll start seeing alterations in levels of consciousness. So we've already kind of looked at Harmony's blood work. I've tried to highlight here in red the things that we really need to emphasize: the electrolytes, the GAP, the glucose, the serum ketones. Other important labs, whether you draw an ABG or a VBG, the literature is suggesting, and you talk to the physicians that deal with DKA, either is acceptable. Make sure you throw a lactate and a serum osmo in there. And then based on individualized presentation of the patient, they might need a cardiac troponin. If you're suspecting they're having an acute myocardial infarction, you might want to send them for a CT of the abdomen or pelvis if you think there's something infectious wise or surgical wise that needs investigation. You might want to do some cultures and of course our pregnancy test. So when we look at diabetic ketoacidosis and you hear them talking about the GAP, it's the difference between measured cations and anions. So the anions are the negatively charged elements, your bicarbonates and your chloride. The cations are your positively charged elements, such as your potassium, your calcium, your magnesium, and your sodium. So we know that DKA causes a high anion gap metabolic acidosis because of too much ketone production and the reduction of sodium bicarbonate. In health, we generally accept an anion gap of about 10 to 14 milliequivalents per liter. When we look at the guidelines for diagnosing diabetic ketoacidosis, generally greater than 14 to 15 milliequivalents per liter is one of the things that is going to lead us into the direction that this is a ketoacidosis. The GAP is important because we know the GAP is influenced very much by the degree of acid in the pH, and many of our systems are very enzymatic dependent. They must operate at a certain temperature and a certain pH in the body. So when our pH drops below 7.35, intracellular systems start to fail, and at less than 6.8, there's usually some degree of irreversible damage that occurs to those enzymatic systems, so the body is not going to be working as effectively as it should. So when an anion gap exists, we need to determine what the cause of the gap is. So I'm sure you're all familiar with the term mud piles, but mud piles has sort of been abandoned in the literature and among some critical care docs in the last few years because no one can really remember that we saw an anion gap contributed to a paraldehyde overdose. So a few years ago, there was a new mnemonic that was introduced, and it's called Goldmark. And this is just because it's certainly much more reflective of what is happening currently in the 21st century and the most popular causes. So when you look at the glycols and the oxyproline and the D-lactate, these are new organic acids and acid precursors that have been recognized as causing an anion gap in people. We've got our ketoacidosis there. We've got our renal failure, our ASA overdose. So these are some of the more commonly presenting reasons why you'll see an anion gap acidosis in sort of our modern day patient population. So our differentials, as we mentioned, the alcoholic, the starvation ketoacidosis, the consumption of ethylene glycol and methanol poisonings, you would certainly want to rule that out. Certainly lots of different possible considerations, and I didn't add in this slide the SGLT2 inhibitors and the euglycemic ketoacidosis. So you need to start asking yourself about those things. And we don't do this individually. We do this as part of a team. So we've determined that Harmony is in a DKA. And the other more frequently associated condition that people want to start talking about is the hyperosmolar hyperglycemic state. So I have bolded in red for you here the three sort of main things that separate DKA from HHS. And that is your blood glucose. It will be significantly more elevated in a DK or in an HHS than a DKA. The serum urine ketones will be absent to minimal, but your serum osmo will also be above the 320. When we see HHS briefly occurs 90 to 95% of patients in type 2 diabetes. There's usually some obesity, high body mass index. There's a resistance to insulin in the peripheral tissues, high mortality rate of about 20% versus the less than 1% for DKA. So insulin is still being produced in the body. That's why you see an absent to minimal increase in your ketones. You get a decrease in cerebral blood flow. So that's why they will present often in a stuporous or comatose state, because of the profound dehydration. So you get your elevations of blood glucose, your elevation in serum osmo as it related to the osmotic diuresis, and the absence of ketoacidosis. That teases out DKA from HHS. So confirming the diagnosis, and when we look at all the guidelines that are published, Canadian Diabetic Association, the American Diabetic Association, the Endocrinological Society in the United States, the European guidelines from Australia, and it's usually Europe, North America, and Australia where we get most of our information. The guidelines are fairly consistent in generalist approaches, but there's always little nuances. So because this is a North American conference, I was going to focus on the American Diabetic Association, since that's what most people use when we confirm the diagnosis. So it's blood glucose greater than 200 to 250 milligrams per deciliter. Your arterial pH is less than 7.3. Our bicarbonate level is down because of the compensation for the acidosis. Your anion gap has increased as a result of the ketones in the acidotic state, and you get the presence of ketones. That is confirmatory, and Harmony meets all of that criteria. This is diabetic ketoacidosis. So the big question that comes up is, does she need admitted to ICU? The American Diabetic Association had put together a list of sort of mild, moderate, and severe. Talking to one of my nurse practitioners the other day at the hospital on a medicine ward, I was quite surprised, honestly, to hear that they admit a large number of diabetic ketoacidosis patients, but they infuse insulin infusions on the ward. I had no idea they were doing that. I honestly thought that if you needed a continuous IV insulin infusion, you were usually in some degree of significant acid-base imbalance. But he said, you know, Gene, the mild to moderate folks, we can generally manage them on the ward. But if they tend not to be responding, that's when we're going to be admitting them to the ICU or calling you folks for a consult. So there's some question in the literature about whether or not there's utility in this anymore, since patients don't often read textbooks and they kind of cross from mild to moderate and severe and have elements of all three kinds. So it really is a clinical judgment on whether or not the patient with DKA is going to be admitted into the ICU. So Harmony, again, meets all of the criteria here, and really the systemic effects of diabetic ketoacidosis are really dependent upon sort of the age of the individual, the severity of the acidosis, and the degree of circulatory volume depletion. That is the clinical judgment that's going to depend whether or not our patient is going to be admitted to the ICU. So we're going to decide Harmony's coming to the ICU. So if I was to say to you, given what we've talked about with the pathophysiology of diabetic ketoacidosis, you know the signs and symptoms, you know the labs we need to do, you know the differences in different types. So we're going to say this is a straight-on, full-on diabetic ketoacidosis. What is your first and highest priority for Harmony? Do you think you want to administer IV fluid? Do you want to intubate and mechanically ventilate for the pH of 6.9? Do you want to initiate some IV insulin because her blood glucose is over 40 millimoles per liter? Or would you like to correct the electrolyte abnormality? So if you could pick one of those things, and I'm going to suggest to you that only one of those things is the most important, what would you like to do? I know what you're thinking, Jean. I'd probably start working on all of that. I think maybe 3 of the 4 things you might want to start working on, but there's one that's super important. And if you said it's the IV fluid therapy, you are absolutely correct. So IV fluid is your number one go-to in diabetic ketoacidosis because 1, we need to re-expand the intravascular volume, and 2, we need to restore the tissue and renal perfusion and get oxygen to the cells and the tissues of the body. The question becomes, though, during IV fluid resuscitation is, what fluid do I need to give? When do I need to give it, and how much do I need to give? So the guidelines are fairly consistent that we're going to be giving an isotonic solution. So there are reports in the literature of people giving saline, Ringer's lactate, and plasmolite. Most folks are still advocating for the 0.9% normal saline because it's isotonic in the body. Now, I do know that there is going to be the argument that the patient is going to get a hyperuremic metabolic acidosis from giving too much chloride in the saline. However, it's usually transient and the body is usually able to adapt and correct itself over the next few days after we've started the initial treatment. However, if you want to give Ringer's lactate or plasmolite, I'm not going to say you can't, but on the flip side, I'm going to say that there's no evidence that I've currently seen or that's been published or anyone that I've talked to suggests that a balanced electrolyte solution improves time to resolution of DKA. So there. So we can have that disagreement, but again, it's going to depend upon your institution, the protocols you have there, and physician preference, let's be honest. So the infusion rate, you need to just hang up a liter of saline and give that wide open and give that immediately. They are incredibly dehydrated. You need to start replenishing the intravascular volume. So we suggested a rate of 15 to 20 mLs per kilo. Our goal is euvolemia. We don't want to under-resuscitate because they'll stay in their DKA. We don't want to over-resuscitate and predispose them to cardiac and respiratory issues. After the first hour, then we start deciding whether or not we're going to continue with the saline or if we're going to change to a different solution. So we're usually dropping it after the first hour or the first 2 or 3 hours to a 4 to 14 ml per kilo per hour. So still a pretty fast rate of about 250 to 500, but we're going to titrate it to clinical assessment. We're going to look at our labs. We're going to look at our glucose. We're going to look at our ketones. We're going to look at our lactate. We're going to look at our hemodynamic status. We're going to look at our systolic, our diastolic, our mean arterial pressure, and whether or not it's improving or if we're still sort of behind with a fluid volume deficit. So those are all the things that we're going to take into consideration on which fluid we're going to use next. And after we've initially hydrated the patient, we need to think about both serum sodium and we need to think about sugars. So if we have a normal serum sodium after initial resuscitation, you're generally okay to change to a half normal saline. If you see that they're developing a hypochloremic metabolic acidosis and you're uncomfortable with that, you could switch to Ringer's. But once the blood glucose reaches less than 200 milligrams per deciliter or less than 11.1, we're going to add the dextrose, but switch our sodium concentration to a half saline, and we call it the 2-bag method. Some of you might be using the 1-bag, where you just continue to switch different IV solutions, or the 2-bag method. You have 2 bags that are similar, both have potassium supplementation in them, but one IV bag will have dextrose, the other will not. So every hour, in response to your electrolytes, your blood glucose, your degree of acidosis, you are able to titrate the IV bag with the dextrose in order to maintain your blood glucose between 150 to 200 milligrams per deciliter. We want to add the dextrose because you want the insulin to continue to be administered. This is where when blood glucose starts approaching normal values, the first thing nurses want to do is turn the insulin drip off. Stop! Don't do that because your patient may still be in a degree of ketoacidosis and it hasn't resolved yet. So we want to continue to administer the insulin because the insulin will help shut off the acidosis and the ketogenesis. It will also simultaneously avoid the hypoglycemia and help clear the ketones. So in IV fluid resuscitation, when we start resuscitating and we're thinking about administering IV insulin, key learning point, our serum potassium must be greater than 3.3. If your serum potassium comes back and it is less than 3.3, please do not start your insulin. You need to start administering potassium supplementation. We know the administration of insulin drives potassium into cells. If it's less than 3.3, potassium will move extracellular to intracellular and you will precipitate a cardiac arrest. Don't do that, and I know that you wouldn't. So once we've got some fluid resuscitation, we could certainly start looking at insulin therapy next. Again, it'll stop the lipolysis or the breakdown of the triglycerides. It'll stop the ketogenesis or the ketones from forming. So it's almost like heparin. It doesn't directly reduce the ketone concentration. So heparin won't dissolve the existing clot. But what insulin does, it inhibits new ketone formation. And what heparin does, it prevents extension of the clot. So much the same thing. So insulin therapy, we become focused on that blood glucose level, and we do need to look at it, but insulin therapy is the key cornerstone of stopping the breakdown of the triglycerides and stopping the ketone formation. So we want to reduce the blood glucose levels as well and help correct the electrolyte issues. And as we start administering insulin, key questions that come to us as critical care nurses is, how quickly do we want the blood glucose levels to drop? Should we bolus with insulin or not? And do I need to worry about the electrolytes? And we've kind of already talked about the potassium. So when we look at insulin infusions in DKA, the evidence suggests now that we're going to initiate at a 0.1 to a 0.14 units per kilo per hour. The evidence is pretty consistent. Most of the major guidelines are saying that an insulin bolus is not required. I think the UK guidelines are the only ones that are still suggesting that that is one option. The reason for backing away and eliminating the bolus is because of the significant drop in blood glucose, not been beneficial for patients. So starting it and initiating at a fixed weight-based rate seems to improve and enhance patient care outcomes. We're going to use regular insulin because it's got a shorter half-life. Our insulin rate will be adjusted on the resolution of the anion gap, our blood glucose levels, and our electrolytes. How much are we expecting our blood glucose levels to drop? Probably about 3 to 4 millimoles per liter per hour, or 50 to 75. If you do not see an increase in the first hour after initiating your insulin infusion, you need to go up on the insulin infusion. Most guidelines are suggesting you increase the rate once per hour from perhaps 0.05 to 0.1 unit per kilo per hour. If you're approaching 200 milligrams per deciliter, you could certainly start decreasing your rate and adding the dextrose, but not turning the insulin off. But if the blood glucose is falling too quickly, you need to decrease the rate at least 0.05 units per kilo per hour and do more frequent blood glucose monitoring. So adjusting the insulin rate based solely on blood glucose values will lead to a reduction of the insulin you're giving, but it also won't stop the ketoacidosis. So it may prolong the duration. So let's just keep the insulin running, even though you're approaching near normal state, because we want to make sure we've closed the gap and eliminated the acidosis. And when we start looking at electrolytes, as we've already mentioned, the initial serum potassium levels don't reflect the total body potassium correctly. You actually have a deficit and not an increase. And there's multiple different factors that we've discussed that have already talked about it. When we have a patient that we're managing harmony in DKA, we want our goal to be 4 to 5 milliequivalents per liter, because that's our target So potassium supplementation is going to be necessary. So even if we're at the range of 3.5 to 5 milliequivalents per liter, we still need supplementation. So guidelines, 10, 20, 30, 40 milliequivalents, you need to have something in that bag, be monitoring your potassium level, and it's still safe at 3.3 or higher to infuse your insulin. Less than 3.3, I don't want you to do that. And if it's greater than 5.5, you don't need to infuse potassium. You can start the insulin, but you need to monitor your potassium, because with the administration of insulin, I feel like I am an Oliver Stone movie, right? I'm hitting you over the head to make a point. It will drive potassium back into the cell, and the patient can become hypokalemic. When we look at serum sodium, this is complex. So the patient in DKA looks hyponatremic, but there's truly a sodium deficit of about 7 to 10 millimoles per kilogram. And it's only because primarily of the dilutional effect of glucose and the change in osmotic pull from the hyperglycemia. Do we need to correct it? We do. It's complex. So in a nutshell, what we need to do is we need to calculate the true serum sodium using the correction factor. I've put the correction factor down there, but there's lots of different correction factors that are out there. So we want to increase our measured serum sodium by 1.6 millimole per liter for every 100 milligram per deciliter rise in serum glucose concentration greater than 100 milligrams per deciliter. We need to, so in a nutshell, what that's going to be is the expected serum sodium if the blood glucose was within normal range. We need to calculate our free water deficit. We need to consider ongoing losses from NG tubes, Foley catheters, lines, tubes, drains, etc. with sodium. The important key take-home point here is we'll let the physicians figure that out, how they're going to correct the sodium. Know that it needs to be corrected. We would never, ever correct it with hypertonic saline. It is not that dire that you need to correct your deficits in serum sodium and DKA with hypertonic saline. Normal saline will suffice. When we look at bicarbonate replacement, the only true indication for giving bicarbonate in a DKA is if the pH is less than 6.9, the patient is in severe hyperkalemia, or they're in extremis and they're on the verge of respiratory and or cardiac arrest. Evidence suggests that the administration of sodium bicarbonate does not appear to have any beneficial use in DKA. It does not decrease the length of time to resolution of DKA. It doesn't decrease morbidity and mortality. It doesn't decrease length of stay. It doesn't decrease length of stay in the intensive care unit. So it's there in case we need it. And authors are suggesting if we need to give it, it should be given probably over 1 to 2 hours as a mini infusion, not direct IV push. You'll reserve the direct IV push for those in extremis cases. When we look at phosphate as well, phosphate not really plays a big role. I know we need ATP for energy, but again, consensus is if it's less than 1 milligram per deciliter or less than 0.32 millimoles per liter, then you can replace it, but it's not a hill I'm going to die on with DKA. Okay. When we look at the supportive care and our priorities on admission to critical care with Harmony is looking at airway, breathing, circulation. If that's not in immediate danger, we'll initiate our hemodynamic monitoring. Let's get our large bore IVs, but our emerge teams do excellent jobs of getting the patient prepped and ready for the ICU. We've got our Foley catheter, we're monitoring our output, we're initiating our fluid resuscitation. So all the good stuff that we do for patients when they come in, so the GI, the DVT prophylaxis, that's all part and parcel of management and care of the patient with diabetic ketoacidosis. But the real issue becomes, do we need to intubate Harmony? So there's her blood gas, 6.71. She's not hypoxemic, but the bicarbonate is 9 and the SAT is 89%. So do you think Harmony will turn around with our insulin, our fluid, and our resuscitation, correction of the electrolytes? Do you think she will turn the corner and not require intubation? Well, that's tough to say. I'm not entirely sure. Again, this will be a clinical judgment. The pH is really low, which is kind of getting outside my comfort zone. But we had a patient with DKA last fall in our unit. He was admitted. I swear the pH was like 6.19. And I thought, my goodness, it's like Sigourney Weaver and Aliens. You're spewing acid for blood. And he was not intubated. So the real difficulty with the intubation is, how are we going to match their ventilatory demand if we choose to intubate them? So key learning point, if you don't have to intubate them, don't. The administration of IV fluid, the correction of the blood glucose, the correction of the electrolytes, the body is a remarkable organ. It can start turning itself around, but that's why as critical care nurses, that vigilant observation of the patient and monitoring trends over time is so critical. What we really need to consider is the patient getting into any degree of respiratory muscle fatigue or exhaustion? Again, oxygenation problems incredibly rare. It does look like they're really breathing, but that's the body's ability to try to compensate for the significant acid-base imbalance. I would strongly suggest you avoid things like BiPAP, in particular if your patient has an altered degree of consciousness or they start displaying any degree of hemodynamic instability. It's too risky that they'll aspirate. High-flow nasal cannula is good. If the decision to intubate is made and you do need to intubate them, it's a clinical decision. You need to have the most experienced provider in the room. I would give them some IV fluid as a bolus before you intubate them. Sodium bicarbonate pre-procedure is probably very beneficial because if you happen to give analgesia, sedation, which will decrease our respiratory drive, and any degree of paralytics, that will completely remove the patient's ability to compensate. That will cause an increase in acidosis, and your patient is a sitting duck for having a cardiac or respiratory arrest. When you get the patient intubated with the largest size endotracheal tube you can to help decrease the resistance, you need to increase the respiratory rate. So you're going to have it set at least 20 to 24 breaths per minute. And your minute ventilation, normal ventilation, the volume of air that the patient moves in and out of the lungs in 1 minute is anywhere between 3 to 12 liters. You're going to have to set it at least 14 to 20 liters per minute because we're going to try to match the patient's respiratory rate, tidal volume, and ventilatory demands. I would probably have the code blue cart just maybe outside the room to ward off some evil spirits. When we look at criteria for resolution, so we've got all this going on. We've got the fluid resuscitation, the insulin, correction of electrolytes, the supportive care. We're going to say that we did need to intubate Harmony and put her on a full support mode of mechanical ventilation. We want to see, how do we tell if we're all headed in the right direction? So the criteria for resolution is when your blood glucose is less than 200 and any two of the following. The sodium bicarbonate is continually rising, so it's greater than 18. Your pH, whether venous or arterial, is greater than 7.3. The gap is starting to close. It's starting to narrow. It's starting to decrease within normal limits. Those are all good indicators that our condition is resolving. So Harmony's condition is improving. She's awake and alert. She still has her IV insulin running. She still has her dextrose running. When would you want to stop the insulin infusion? When the acidosis has resolved, the gap is closed, the bicarbonate is greater than 18, or all of the above? So I think I've given you several hints during the course of our presentation today. So if you were to say it's all of the above, absolutely. That's when you want to start turning off the insulin drip. But before you turn off the insulin drip, we have to transition to subcutaneous insulin. So subcutaneous insulin should be started at least 2 hours prior to turning off the drip. Now, people have said, well, Gene, can we not give subcutaneous insulin in the ICU when they're admitted with severe diabetic ketoacidosis? Well, there's some reports that it has been done. However, with the degree of acidosis, the ketonemia that occurs, the potential for vasopressors and inotropes and fluid volume deficit, we just don't know the uptake of the insulin in the subcutaneous tissue, the absorption, the effectiveness, the efficacy of it. So it's probably best to stick with IV because then we can be assured there's a route and the patient is getting it. So transition period, we need to continue our IV insulin for at least 2 hours after we start the sub-Q, and also necessitating checking blood glucose and your metabolic profile again. So when the patient is awake, alert, they're liberated from mechanical ventilation, and they've started eating again, with our previous known diabetics and their insulin, often we're able to start them to their home dose. If they're insulin naive or brand new onset diabetics, we'll start generally at about 0.5 to 0.7 units per kilo per day. We take a multi-dose approach. So the multi-dose approach is 50% of that total dose is going to be long-acting once or twice a day, and the remaining 50% is broken up between breakfast, lunch, and supper. Careful monitoring of blood glucose levels is essential as we're transitioning to sub-Q insulin. Any reason why the patient's not liberated, they're not able to eat, they're not able to drink, we're going to continue the IV insulin, and we're going to continue the IV dextrose and continue to monitor. When we look at complications of DKA, this is only a partial list of all the different complications that can occur. Hypoglycemia is most common because we've kind of overshot our targets with blood glucose management. Hypokalemia. I was reading a very interesting article last night. It was comparing different protocols in Canadian hospitals. Yeah, I'll use us as an example. 3 teaching hospitals, and what sort of problems and issues were encountered during management of DKA. And it was written just a few years ago. And one is hypokalemia. We are not replacing our potassium as effectively as what we should. 25% of sites were still giving the bolus insulin when you get much better control, or sort of the tendency is that the literature suggesting we are achieving better control with the continuous infusion. That IV insulin has been discontinued too early, and in 25 to 30% of cases, it was discontinued before sub-Q insulin had been started. And the last thing is that we're giving sodium bicarb way too often. So those are some of the things that we need to reflect on ourselves as practitioners when we're managing patients with DKA. So about 16 to 20% of patients that present with DKA will have some degree of acute kidney injury. Sometimes it necessitates continuous renal replacement therapy. Acute respiratory failure is not uncommon. The pulmonary edema, we know that Harmony came in with pneumonia, so all the good things to treat pneumonia, ventilator-associated pneumonia, our ICU bundles, our antibiotics. Sometimes it can progress to ARDS. Rhabdomyolysis is reported in about 11 to 15% of patients just because of the extreme dehydration and the hypercoagulability that patients are at risk of DVT events and stroke. When we look at cerebral edema, I'll spend a second talking about this because everybody worries about the serum sodium and cerebral edema. Much more reported in the pediatric and the adolescent patient population, incredibly rare in ICU adult patients. So when we're looking at cerebral edema, there's usually the problem is with the serum sodium and overzealous administration of sodium bicarbonate that are usually sort of the primary factors responsible for contributing to cerebral edema or some underlying condition. Prognosis of DKA is very good. As we mentioned, mortality rate less than 1%. The average length of stay in the hospital is usually about 3 to 4 days. When we're looking at worse outcomes, who is going to fare the worst when they present? If they're in a comatose state, so decreased level of consciousness, if they're hypothermic on admission, or they're oliguric and they're not making any urine, that coupled with if you happen to be elderly and you've got a pre-existing, coexisting illness or condition that's contributing to that, that can certainly lead to longer hospital stays and increased mortality. So when we look at prevention and education, we need to look at both the patients and ourselves as healthcare teams. So blood glucose monitoring, how patients are using oral hypoglycemic medications, how to use their insulin with all the insulin pens out there these days and all the differences in different types of oral anti-diabetic agents. It's really fascinating. sort of the level of knowledge of people. Some people consider themselves very knowledgeable, and you know as well as I do, they're not very knowledgeable. We need to enhance that. And some people are super knowledgeable about their conditions. And I always like, especially when the diabetics or the asthmatics come in, is let's talk to the patient. Let's talk to the family. They're the best source of information for telling us what works and what doesn't. If you have a sick day and you happen to be diabetic, you don't generally routinely discontinue your own insulin and checking your blood glucose and your ketones frequently and knowing when to call for help. And some of our less fortunate folks having avenues available for them. Interesting story on NBC News the other night. Over 100 million Americans and 7 million Canadians are without a family physician. So it's really tough to have compliance when you might not even be able to see a family physician or a primary care provider. So trying to be advocates for folks and getting some supports in place to help them as best we can prior to discharge from the hospital. Our take-home message today about DKA is, one, we've noticed an increase in DKA admissions over the last 15 years. We need to stay frosty. Primary causes of DKA that we see in adult critical care is insulin omission or some type of infection, chest, gut, or septic shock. Key characteristics of diabetic ketoacidosis: you get your hyperglycemia, or you've got a diagnosis of diabetes. Metabolic acidosis, that's your high anion gap and the presence of ketones. Guidelines are well published. That's a study for someone to determine why we're not following guidelines as effectively as what we should. But we always need to leave the room. That's not probably fair of me. We need to leave the room for individualized assessment because our care needs to be individualized. Our priorities are IV fluid resuscitation for DKA patient, correcting the electrolyte abnormalities, administering the IV insulin, and providing good supportive care, monitoring trends in patient's condition, and overall preventing complications. Folks, it has been such a pleasure to be here today at Virtual NTI. Thank you for including me as part of your virtual NTI learning experience. You can find me on Meta, Instagram, X, LinkedIn. I like to hang around at the conference. Maybe you might be going to Denver. Maybe you might see me there. Or if not, I've certainly enjoyed presenting to you today. So you can email me again at heartlung44@shaw.ca. You can find me at eugenemondor.com, and stay tuned because there's going to be a live interactive question and answer period. So you can ask your questions and I'll be with you in just a few short minutes. So thank you very much. Thank you for the incredible job you do each and every day. Thank you for making a difference, and have a wonderful day at Virtual NTI.